Yeah, so I guess if we minimize it, then we go to complete. I think we actually want to minimize it though. We'll have to X out of it.
Mhm.
And then, where's that? And then it does just show up. Alright. Good. Yeah, the same.
Okay.
And then,
If I just stand here and talk.
then it will
Okay.
catch it, I think. And yeah. I don't understand them. So if you
Oh, you
want-
usually don't?
I don't, but you certainly can.
Okay, I probably will.
You certainly can. So if you decide to move around, or even this will even like move it through the questions. If you want to move around. Okay. So they're both. Sounds good. So I'll introduce you in like a minute.
That's the reason.
You put them. You got it. Which is exactly how it's spelled.
Yes.
I know. If I was about to read it, this would not be a problem.
We normally are there like mics around the room, or should I repeat the questions if I get any?
I would just repeat them.
Okay.
Yep. There's not any mic around the room. Hey,
How are you?
I'm well.
You beat me to it.
I think we're all like logged in and everything.
Yeah,
Kanaka's started.
it is. That's good.
So hopefully
Okay.
all is good.
Can I double check?
Yeah.
So, capture this. This is already recorded. This just has like copyright protection.
Oh, okay, that's fine.
Yeah, so it'll capture your audio and everything, but when you switch to like your presentation and stuff, then
I think we need to share. So we have to pick share screen.
probably
Window.
does.
I
Okay.
don't know if you suggest doing something else. But if it was, and that's fine. Those questions are fine as well. So that's kind of crazy.
Entire screen.
That's what I had.
Yeah, you were right.
It was okay. Can you put the audio real quick?
Yes.
I always just leave it on this.
Yeah.
Is that fine?
Yeah, that's usually.
There was one time when it didn't record, and I'm just not sure what I did.
Maybe like you. It was already selected, and then when you click on it again, it might tip it away.
Maybe so.
So I mean, everything else is okay. We're already on the screen. So presentation. So right now you're doing the so,
No, I'm gonna do it throughout.
okay. Yeah, that's fine. It'll capture everything that's here. So when you exit this, make this come over here, do your thing here, and then once you get back over here, you start the presentation.
All right. Thanks, Sean.
No problem. I wish Kahoot didn't have copyright.
Yeah, I've done some other things that have that and then fix it.
Yeah. I hope the professor. I forgot. They had it going, and then when I looked at the recording afterwards, it was just, I noticed that like the screen was just blank and it captured the camera stuff. Yeah. I mean,
All right. Thanks. All right. Thank you guys. Good to see your faces. Excited to talk about contraception. We have a guest, as you have seen, Dr. Yukazem, who is doing her PGY2 with Johns Hopkins down the street. Really excited to have her with us today. So I'm going to pass it off to her. I know she's got a few more introductory slides But thank you guys for coming. Good to see everyone.
All right, we will go ahead and get started. So again, my name is Grace. Just a little bit about me. This is my first time meeting you all. I was born and raised in Houston, Texas. I did my undergrad and pharmacy school at the University of Texas at Austin. And I moved up here last year for PGY1 at the University of Maryland, Baltimore Washington Medical Center. And I'm currently doing my PGY2 in pain management and palliative care at the Johns Hopkins Hospital. So if any of those things interest you, please feel free to talk to me about them. So we're going to get started. So by the end of this presentation, I hope that you all are able to understand the role of sex hormones in the female reproductive cycle, distinguish adverse effects of different components of hormonal contraceptives, explain contraindications to different types of contraceptives, and select either a contraceptive product or emergency contraception based on patient-specific factors. So we will start with a brief overview of menstruation. I won't spend too much time on this. But in general, there are some hormones that contribute to menstruation. First comes from the hypothalamus, so that's your gonadotropin-releasing hormone, or GnRH, and that works by stimulating secretion of gonadotropin, so that's your FSH and LH. And those come from the anterior pituitary gland and work to stimulate follicular growth in the ovaries and stimulate estrogen secretion. That's what FSH does. And then your luteinizing hormone, or LH, is important because it has a surge that causes ovulation and results in the formulation of your corpus luteum. And then lastly, we have estrogen and progesterone. Those come from the ovaries. And estrogen works to inhibit implantation by altering secretions within the uterus. And it inhibits FSH and LH for most of the cycle, and also stimulates then FSH and LH during pre-ovulation. And your progesterone works by thickening the uterine lining and also inhibits FSH and LH. And just for reference, if there is a smiley face at the top corner, you can't really see it, but they're on the slides. These are the slides I'd like you to focus on in terms of exam preparations and questions and such. So. And then please feel free to ask questions throughout. You saw by my specialty, this is not something that I typically deal with, but if I can't answer your question now, I'll follow up with you later. All right, now to talk a little bit about the menstrual cycle. The average menstrual cycle lasts about 28 days. However, this varies from person to person and can vary from anywhere from 21 to up to 40 days, or 21 to 35. So there are three main phases of the menstrual cycle, first being the follicular phase. This is the first half of the cycle, lasts about 10 to 14 days. This is when your GnRH stimulates the release. Okay, can't see my mouse. Stimulates the release of FSH and LH. And so FSH then stimulates the estradiol secretion and stimulates the follicles to develop. And one in particular becomes the dominant follicle and releases estradiol. And then LH then causes an increase in androgen. So then you have ovulation that occurs mid-cycle. This is when mature follicles rupture from the ovary and release an egg. And this is where we talked about the surge in LH that occurs right before ovulation. That's seen in the middle of the diagram. Then the luteal phase is the last phase of the menstrual cycle, and that's where progesterone is the more dominant hormone. So progesterone maintains the uterine lining and prevents GnRH, FSH, and LH from being released. And if there is no implementation or no embryo, the corpus luteum degenerates, progesterone levels drop, and that's when menstruation is triggered. So it's basically withdrawal bleeding. So that was a little bit of an overview of menstruation, and it was just more to provide background to now we'll start talking about contraception. So just for some general information, sexually active people should have access to reliable contraception. Education should be provided in an unbiased manner. And as pharmacists, we should be helping to find a method that aligns with their personal needs and preferences. And contraceptive counseling optimally includes sexually transmitted infection or STI information. So as we go through, you'll see I'll talk about certain contraceptive methods that do offer STI protection versus do not. And emergency contraception should be discussed and made available to everyone. So the main contraceptive methods that we will be talking about throughout the presentation, there is your non-hormonal and hormonal. I have a lot of slides on non-hormonal, mostly for your reference, but I will go through those pretty briefly just to provide some background. So that's, I'll go through that. So starting with efficacy, abstinence is the only birth control method that is 100% effective. And in general, the simultaneous use of 2 or more methods improves efficacy. And any studied method correctly is done better than none. So a lot of the data with the effectiveness of contraceptives comes with either like a general use, like how we see it in the population, or a perfect use rate. So in general, these are the ones that we'll be going over. So your fertility awareness methods, spermicides are your least effective, and then all the way up to IUDs and sterilization are your most effective in preventing pregnancy. So we will start off with the non-hormonal contraceptives. First is the fertility awareness method. This is also known as natural family planning or the rhythm method. The failure rate, failure meaning resulting in pregnancy, about 24%. So about a 1 in 4 chance of getting pregnant using this method. And then this method assumes that an egg is released once in each menstrual cycle, and the egg lives up to 12 to 24 hours. And also sperm can live to 5 to 6 days, and a woman is fertile for as long as 6 days before ovulation and 2 to 3 days after. So this method makes a general assumption, but as we know, everyone is different in terms of how many eggs they release and how long they last and such. So there are different fertility awareness methods that exist. There's one using the basal body temperature, where they take the temperature every morning, and it's theorized that a rise in temperature happens right after ovulation, so finding that sweet spot in between. And there's also the cervical mucus method that theorizes that increased cervical mucus happens on the most fertile days. And then there is the calendar method, which is kind of complicated and probably hard to do, but it's where you track your menstrual cycle for 8 to 12 months, the first day of your period being day 1, and then you count the number of days between each cycle, and you make this sort of calendar to find out which days you're most fertile. These are all pretty complicated. In terms of pros using this method, it's generally inexpensive, quote-unquote more natural method, no medications to worry about in terms of adverse drug events, and it can be combined with other methods as well. In terms of cons, they're pretty moderate failure rates, requires regular cycles like we talked about, and long periods of abstinence is required. If you think about the calendar method, where you're tracking for 8 to 12 months, and then this method offers no STI protection. So spermicides, they work by killing sperm or blocking entrance into the cervix. There are different types. There is an active ingredient that is involved, and the failure rate is about 21%. So this one also has a pretty high failure rate. This one also offers no STI protection and may possibly cause an increase in susceptibility to HIV acquisition. So pros of this, most of these are easily accessible and available over the counter. Cons can be messy, and then may increase STI transmission with the increase possibly of HIV. There is next the withdrawal method. This one also has a fairly high failure rate. This one also offers no STI protection and is most effective when it's used with other forms of birth control. So this one works by preventing semen from entering the vagina, which could increase the risk of pregnancy. Now we'll talk about the different barrier methods. So again, the effectiveness depends on motivation to use them consistently and correctly. So there is a male or external condom and female or internal condom. Female condom, I just listed some counseling points for your reference. I think y'all might have a self-care class that I heard about, so you might be talking about this or maybe already have. So I just listed those here for your reference. Pros with the male and female condoms, they offer STI protection, and cons is that people might have an allergy to the ingredients that are used, and it has a high user failure rate and possibility of breakage. And the female condoms, I included important counseling points. I think most important one for this, it's usually recommended for one-time use and can be inserted in advance, but it also offers STI protection. Then some of the other barrier methods, there is a sponge, cervical cap, and diaphragm. These are all fairly similar. They're inserted intravaginally, and most of the time they either contain spermicide or have to be used with spermicide. They have similar failure rates, and the difference with these is that some have to be prescribed by a provider, and some can be found over the counter. All right, so now we'll talk about the copper IUD or intrauterine device. This is actually the most effective way to prevent pregnancy after sex when inserted within 120 hours. We'll be talking briefly about emergency contraception towards the end, and I'm going to reference the copper IUD. So it works by changing sperm motility. So the sperm cannot make it to the egg for fertilization. However, with this, it's inserted, so there is a high risk of infection or uterine perforation when compared to other emergency contraceptive options. As you can see, the failure rate is very, very low. So there are some contraindications and warnings with the copper IUD. Most importantly being that if they have acute pelvic inflammatory disease or PID, or have known or suspected uterine or cervical cancer, so anything having to do with infection or worried about cancer in the pelvis, cervix, and uterus, we would not want to use intrauterine device. Pros is that it is hormone-free and it's effective immediately, and it can be left in for up to 12 years. I think most recommend about 10 years, so it can be left in for a very long time. Cons is that it can make periods heavier or cramps worse, and it's fairly expensive, but when you weigh it against the amount of time that it can be left in, it might balance out for some people. Also that it has to be placed by a prescriber, so someone would have to go into an office, make an appointment, so some barriers possibly there. And it doesn't offer any STI protection. All right, and then there is sterilization. These also have very low failure rates. These are just two of the more common methods. First one being vasectomy. That is a procedure that is done to keep sperm from going into the penis. And then there is tubal occlusion, or more commonly known as getting your tubes tied. And it's performed on the fallopian tube and has a very low failure rate. I don't know if anyone watches The Office, but this was one of my favorite scenes from there. But in terms of pros of sterilization, it's very effective. It's a one-time decision and very few side effects. Cons is that it might not be readily reversible, and so people might regret their decision and not be able to go back and reverse it. Also offers no STI protection, and with getting your tubes tied, there is a risk of ectopic pregnancy. All right, so I have a complete. Let's see if this works. Any questions so far about any of those? Okay. Give it like 30 seconds. Alright. Let me know if anyone's still having trouble getting in. No. Okay, we're gonna start. Okay. First question, which of the following is directly responsible for ovulation? All right, LH is the correct answer. Like we talked about, there's a surge of LH that is that's responsible for ovulation. Any questions about that? Dr. Fold, I don't know who anyone is. Oh, welcome. Yeah.
Oh, I'm also not placed. That is not me. But I'm glad that my namesake is doing well.
All right, this one's a true or false question. No one method of contraceptive is 100% effective except for abstinence. All right, so that is correct. It is true. Abstinence is the only method of contraception that is 100% effective. All right. Last question of this section. Which of the following are considered barrier contraceptives? All right, yep, all of the above. Okay, I'm gonna see if I can pause it. Or just exit out. Let's see. Okay. I think I'm doing it. Yay, I did it. Okay. That was just a warm up. They're gonna get harder from here. No, I'm just kidding. Okay, so I have the questions listed on the slide for you all. So again, LH, that's the mid-cycle luteinizing hormone that results in the release of the egg from the ovary to the fallopian tube. And then most of you guys got this one correct. All right, so now we'll start talking about the fun stuff, the hormonal contraceptives. So we'll start by talking about combined oral contraceptives, or COC is how they'll be referred to throughout the rest of the slides. And so these work by inhibiting ovulation through the combined action of progestin and estrogen. So estrogen is normally in the menstrual cycle, you get an estradiol surge from the dominant follicle that we talked about, which causes ovulation. And so by giving estrogen, it inhibits ovulation because there is this now a constant level of estrogen rather than a surge. And so it also suppresses the release of FSH and LH, which leads to the blunting of follicular growth. Yes. So again, if you go back to the menstrual cycle, there is an estradiol surge that comes from the dominant follicle, and that causes ovulation from the LH surge. And so by giving estrogen, there's now a constant level of estrogen in the blood, and so there's no longer a surge. And so with that constant level, it inhibits ovulation. It's just maintaining because your estrogen suppresses FSH and LH. And so without that follicular growth, then there's no ovulation. And then progestin is the other part of the COCs. So it inhibits ovulation via suppression of cyclical release of LH from the anterior pituitary. And so if we go back to the menstrual cycle, progestin is naturally released during the luteal phase. And so giving progestin also modifies your endometrial lining and can also be inhibiting FSH as well. Another mechanism is that it secretes thick cervical mucus and inhibits capacitation. So that's a secondary mechanism of progestin. But primarily the two work by suppressing those hormones FSH and LH. And so if you notice in these products, there is not specifically estrogen and progesterone or progestin. So there are different types or derivatives. For estrogen, most commonly it'll be ethinyl estradiol, or EE, is how it's usually referred to in the slides and also on different products. That one is the most common. And then for progestin, there are a lot of synthetic progestins that are derived from testosterone or progesterone. And then drospirenone is a 4th generation progestin, and it's the least androgenic. So I will talk about that here. Sorry, it's a little bit blurry, but I just wanted to go over the different classes of progestins. First being, I would mainly want you to focus on the progestin and androgenic effects of the different ones, just in general as a class. So norethindrone was one of the first more common ones. That's pretty neutral. And then if you look at levonorgestrel, sorry, I'm terrible at pronouncing these, that one has a lot of progestin, but also is very androgenic. So whenever we talk about side effects of different hormones, selecting one that has maybe one that's less androgenic or more, has more progestin, depending on what you want, will be important. And we talked about drospirenone, which is the least androgenic of all of them. So in general, if someone's experiencing androgenic side effects and they would like to reduce those, we would recommend switching them over to possibly a formulation with drospirenone in it. So I would start this slide. This is important to know in terms of hormone side effects. So there are different side effects that come with an increase in estrogen or decrease. So with too much estrogen, we can see nausea, vomiting, bloating, hypertension, breast tenderness. And so if someone comes to you and they are on a combined oral contraceptive and are experiencing some of these side effects, we might want to opt for a product that has less estrogen. And then the opposite is true. So with too low of estrogen, they might experience early cycle spotting. So it's spotting within like the first half of their cycle, or may have very light or no period. And so opposites, if they have some of these symptoms, you might want to opt for a product that has a bit higher estrogen levels. Then progestin, with too much, you might see hunger, weight gain, and then with the androgenic side effects like acne, oily skin, hair loss, with those, we might want to switch to a product that has less androgenic side effects, or opposite. And then too low progestin results in late cycle spotting. So if it's early cycle spotting, that's too low of estrogen. Late cycle is a little bit too low of progestin. And so also with this, you can see heavy flow or clots, and then delayed withdrawal bleeding. So in general, if a patient comes to you and is experiencing any of these side effects, you can look at this chart and say, okay, this is what you're on. What can we do to mitigate this side effect, and kind of do the opposite? Bless you. All right, and there are also many different formulations and types of COCs. This has evolved over time. So first and most common was monophasic, and so this is where every pill is the same outside of the placebo pills, quote unquote. So this has a fixed estrogen and progestin level on the active days. And then there is biphasic, and so this is when all of the active pills have the same amount of estrogen with varying doses of progestin. And then there's triphasic, where it's every week, usually they have a different level of estrogen or progestin. And the thought with these biphasic and triphasic is to try to model the cycle of like a human being, because we don't all have the same amount of estrogen or progestin all the time. However, it's important to know that there's really no advantage of monophasic, biphasic, triphasic. It's kind of just patient specific. There are also extended cycle COCs, and so this 84/7, meaning 84 days of active pills and 7 days of placebo pills. And with the placebo pills, that's usually when the withdrawal bleeding or menses comes on. So if they are on extended cycle, theoretically they wouldn't have menstruation for that period of time. And these are also just as effective as the regular cycle, and the most common adverse effect is breakthrough bleeding. There are also continuous cycle COCs. The greatest issue with this is tolerability due to breakthrough bleeding. And so this is when there are no placebo pills. And so they have the active pills all the time. And I guess a myth out there is that using the continuous or having like no menstruation might lead to a decrease in fertility. However, this has not been shown to be true. So return to fertility is not a concern with the continuous cycle. All right, and there are some absolute contraindications to COCs to consider. A lot of these have to do with estrogen and having estrogen increase leading to different higher risk of DVTs and PEs. And so if a patient has thromboembolic disorders or has a history of VTEs, we would not want them to be on a combined oral contraceptive, mainly because of the estrogen component. And then if they have undiagnosed abnormal vaginal bleeding, or if they smoke greater than or equal to 15 cigarettes per day and are older than 35, the smoking increases your risk of VTE, and then age. The CDC has a pretty comprehensive chart if you want to, I can pull it up at the end as well. It has different risk factors and what they recommend in terms of if they can take a combined with estrogen or if they recommend something else. I think these are the most important ones to know. There are also some relative contraindications such as hypertension, migraine headache with planned surgery or casting of the lower legs might increase the risk of DVT because they're not moving their legs as much, or poor ability to adhere to a daily schedule because these have to be taken every day and at the same time every day. So if a patient is not able to remember to take their medications in the first place, we might not want to do a combined oral contraceptive. So there are a lot of pros of these medications. They are reversible. They also have been shown to have a reduction in ovarian and endometrial cancer by about 50% because of that extra estrogen component. Also decrease in pelvic inflammatory disease, cycle control. Some of the products are approved for things like acne or irregular cycles. So quite a few pros of using COCs. However, there are adverse effects. I think this one is the most important one to remember. These are the more severe adverse effects that we should be counseling patients on whenever they're starting a new COC. So the acronym to remember is ACE. So A is for severe abdominal pain, and this could signal liver problems or gallbladder problems. Then C is for severe chest pain, cough, or shortness of breath, because it could signal things like a heart attack or blood clots in the lungs. H is for headache, that is severe and different. As you might remember, one of the side effects of estrogen is headache. So being able to distinguish whether it's like a regular headache or a very, very severe headache with dizziness, numbness, especially if it's one-sided, this could signal a possible stroke or blood clot. I is eye problems, so vision loss or blurring, which could also signal stroke, clots, and then severe leg pain in the calf or thigh or swelling could signal blood clots as well. So these are all very important counseling points to make sure that people know before they start these medications, especially because a lot of younger people don't think that they're at risk for these types of things, especially like DVTs and PEs, but they do happen for people on these medications. So there are some other common adverse effects that we talked about, but this is just an example. We kind of discussed looking at their side effect and then mitigating that side effect by choosing an agent with less or more of whatever the hormone is that is causing it. And so I just displayed that in a different way here. So with breakthrough bleeding, usually with most of these side effects, they recommend going through 3 cycles or through 3 months before changing because a lot of them can go away after they take it for enough time. And so with things like breakthrough bleeding and nausea, usually want to give it a 3-month trial before recommending changing the agent. But in general, if after 3 months they're still experiencing breakthrough bleeding, the next step would be to figure out when in their cycle is it happening. So if it's early in the cycle, that could signal low level estrogen, so we can go up. And then if it's late in the cycle, it could signal low progestin, so we can go switch to a different agent that has more progestin in it. With nausea, other counseling points, they can take it at bedtime or take it with food, and then it may subside after 3 months. But in general with this, might signal too much estrogen, so we want to decrease. And then we talked about with acne, hair loss, those androgenic effects, we can select a product with lower androgenic activity, which is drospirenone, or select a product with higher estrogen. That's kind of second line. Most commonly, we would select a product with lower androgenic activity. So there is also a progestin-only pill, or a mini pill as it's commonly known. So this one only has northindrone in it, and main thing with this, it requires strict adherence. So it needs to be taken every day at the same time. And if it is taken more than 3 hours after the normal time, it is counted as a missed dose. So with this one, if the patient's not able to be adherent to that strict schedule, probably wouldn't recommend a progestin-only pill. However, if someone is having issues with those estrogen-like side effects, even if they're on the lowest dose of estrogen, we might consider switching them to a progestin-only pill. It is slightly less effective than the combined oral contraceptives, but the difference is not super significant. And then this would also be a good one if we're concerned for things like DVT, PE, those side effects that higher amounts of estrogen can cause. And then other thing with these is that they're taken continuously. There are no pill-free intervals with these. Okay. I'll pause for if anyone has any questions. If not, we will return to the Kahoot. Okay. All right. Is everyone still like on the Kahoot? Good. Okay. Oh, I guess we didn't do this part. Okay, Dr. Cole's still in the lead. I'm rooting for them, whoever that is. All right, which of the following is not true regarding combined oral contraceptives? Give you guys a little bit more time on this one. All right, red triangle was the correct answer. The question was which is not true, and COCs are actually associated with a decreased risk of ovarian and endometrial cancer, and the rest are true. Any questions about that? All right. Next. I will preface that Kahoot only lets me put in a certain, sorry, yes. Decreased risk when compared to nothing. Like, that's a good question actually. I think just because the estrogen is protective against endometrial and cervical cancer, and so when compared to someone who's not taking combined oral contraceptives, that's what it's compared to. Sorry, can you repeat that? Correct. All right, so for the next ones, the question will be to select a product. So I'll give like a brief scenario and have you select a product of what you would recommend switching them over to. All right, yes, I agree with the majority here. So right now we want you to focus on the EE portion of it because they're experiencing nausea, vomiting. It's been going on for longer than 3 months that they've been on this combined oral contraceptive. And so like we talked about, too much estrogen can cause that side effect. And so if it's bothersome, we can do a product with less estrogen in it. That makes sense. Let's see. All right, so with this one, the thing that we're looking at here is the progestin derivative because they're experiencing bothersome acne. And so like we talked about, the different classes of progestin derivatives can have different androgenic side effects. And so with this one, that's one of our more androgenic progestin derivatives. And so we want to switch them to one with less, and that's going to be drospirenone. Does that make sense? So pretty much ignore the brand name, look at the ingredients that are in there, looking at the side effects, think about whether you should be focusing on estrogen or progestin, and then look for one with, for estrogen, you're looking at the dose, because that's the one that changes. Usually it's going to be that EE formulation in all of them. And then with progestin, thinking about the different classes and switching from there. All right. Okay, so next is scheduled a break, but we're still making good time. So it's up to you guys. Do you want like a 5-7 minute break, or would you like to keep going? I'm fine either way. I hear keep going. Cool, we're making good time, y'all. Okay.
Break.
You want a break?
Break.
Yeah, we can do a break. That's okay. Yeah, stand up for yourself. We will come back at, is 2:15 okay? So 5 minutes? All right, cool. Do a 5 minute break.
You need to use the restroom or anything that I can point you in the right direction.
I'm gonna finish like.
Yeah, that's okay.
Okay.
And then you can kind of solidify any points.
Okay.
And you can pause maybe a little more and ask for questions.
Okay.
If you really will come up with some.
Yeah. Okay.
Yeah.
I'll probably do that.
You have the opposite. I have the opposite problem where I'm like, oh my goodness. Yeah. I saw you at 75 slides. And I'm like, oh my goodness, I could never get through that many.
Yeah, but I'm like going.
You're cruising.
Yeah. I tend to, at first I had more, and then cool, it's when you like down, I'm like, I need to.
Try to. Yeah. It's very nice. Yeah. Nice to break it up.
Yeah.
I forgot to even tell you about the break, so I was glad that you had one.
It's okay.
Michael. Let's just go ahead and let's say what's presentation for.
You studying right now? Studying.
I see we're on the same page. I'm gonna with that. Let's just get up one arm. The other name. Yeah.
What are y'all talking
Yes, the tablet part is like the it's the last, I don't really like
like skills. Oh, the tax one.
but that's all it is.
Yeah, who's got Hey, too much registration.
Thursday. Oh, yeah. Yes. How was it? Right, are you asking? Was 2:11.
Yeah, I said. First one, I just want to finish.
Yeah, okay.
Shukran, do you have information?
Thank you. You have a video? I was really well.
Wait.
You know how Michael thinks.
Wait.
She's calling Michael.
But she got a rule. What about you, Jessica?
See, you always can't take.
I can't go down by myself.
We know you never to commit any kind of activity.
Yeah, exactly.
Oh my God. Did you went to the men?
Wait, what happened?
She went to the men.
Oh, I've done that lots of times, yeah.
I just see Oh,
Yeah, it's a really terrifying experience, isn't it? How did I end up in here?
you know
That's
how
to figure out that outside of the door could have been anybody.
do we know?
Okay, that's good.
At least.
Simpson. Alright, what happened, Tom? Sorry,
What is my shine?
I was just thinking I could really go for my puffer coat. Just in my
I've been
office.
complaining all day.
The one that I
I'm wearing a sweater.
Meet someone? You see that look,
She's busy, she don't have time. What do you want?
All right, we will go ahead and get started. Were there any questions that came up during the break that y'all would like to ask before we start with the second half? Everything making perfect sense? Okay, good. All right, so now we will talk about some different initiation methods. There are three main ones. The first one being same-day start, meaning that you take your first pill, your first active pill, on the first day of menses or menstruation. There's another method that's known as the Sunday start, is where you take the first active pill on the first Sunday after menses begins. These two have kind of fallen out of favor for the quick start method, which is where you take your first pill as soon as you get it. This is because they looked at studies between the different methods and found increased adherence whenever they take it right when they get it. It kind of makes sense. If you're thinking, okay, I have to wait now for maybe a month, sometimes they forget to take it or not, or just don't take it. So quick start method is the most common one, but in general you might still hear about some of these other methods like the same day start and Saturday start. Counseling points, there are a litany of them. Proper use is very important, so taking the medication at the same time every day. And then counseling patients on the purpose of the therapy, depending on whether they're using it for birth control or for other methods. Initiation methods, like we just discussed, the difference between the active and inactive pills, and the importance of, unless they're instructed otherwise, to take the whole pill in the pack and not skip the inactive pills unless they were instructed to. Sometimes those pills contain iron, sometimes they don't have really an active ingredient, but just in general being knowledgeable about those things. And then missed dose instructions we'll go over on the next slide. Drug interactions we'll go over as well. Side effects that are self-limiting, such as the things like breast tenderness, mild nausea, or the side effects that acquire immediate attention, or so the aches side effects. And then general counseling that these medications do not offer STI protection. All right, so missed dose instructions can get kind of complicated. My general advice would be to check the package inserts for that specific product. But in general, if they are on a combined oral contraceptive, if they missed one tablet or one day, they can either take it as soon as possible or take 2 the next day. So usually if they are closer to that next dose, just instruct them to take 2 the next time, or if they are still closer to the dose that they missed, just take it as soon as possible and then resume their same schedule.
Question.
Yes.
If they miss it for 2 or 3 days consecutively, what do they do?
If they miss it for 2 or 3 days?
Consecutively, what do they do?
Yeah, I'm glad you asked. I'll talk about that.
Take 4 tablets?
Well, I'll talk about that in a second. Thanks. So yeah, for 2 tablets, if they miss it for 2 consecutive days, for the combined oral contraceptive, they can take 1 tablet twice a day for 2 days. And then from there, with these though, you have to recommend a backup method for 7 days, as opposed to if they just miss 1 dose, they don't really have to do the backup method. And then if they miss more than, or 3 or more, they begin a new pack 7 days after their last tablet. So basically starting over. And then for the progestin-only pills, like we talked about, these ones are very strict with the timing. So if they are over 3 hours late, that counts as a missed dose, so they'd be missing 1 tablet. So if they are more than 3 hours outside of that window, they can take it as soon as possible and then at the next regular time. But then again, if they're more than 3 hours late, they need to use the backup method for 2 days. If they, for the progestin-only pills, if they miss 2 consecutive doses, they take 1 of the miss and then discard the other. And then for progestin-only pills, they just continue until pregnancy is ruled out. So again, with the progestin-only pills, just knowing that the timeline is very strict and they have to take them within 3 hours of their regularly scheduled dose. Cool. Yeah, in general, check the package insert because they'll have very specific instructions in terms of like if they need to use a backup method or how many pills they lost and what to do. And drug interactions, these are mostly with the combined oral contraceptives with the estrogen component. There is interactions with the hepatic enzymes and inducers. And so the anticonvulsants can decrease the effects of the combined oral contraceptives, and antibiotics like fluconazole can increase the effect. And so if there is a decreased effect, they might see some breakthrough bleeding, but if there is an increased effect, they might be experiencing some of those estrogen that's high, like those side effects. So now we talked all about oral contraceptives, and so now we'll talk about different formulations of hormonal contraception. First one being Depo-Provera. This is DMPA, so it's a progesterone derivative, and it is an intramuscular or can be sub-Q injection. So this one is every 3 months, so very long lasting. So for people who do not like to take a pill every day or have trouble with adherence, this might be a really good option for them. Ovulation does not occur for 14 weeks, so if they're a couple weeks late, usually there's some leniency there. And it is not affected by weight or drug interactions because it is a progesterone derivative. Some pros, like we talked about, less adherence issues. There's not that increased thromboembolism risk because there is no estrogen component, no neoplastic risk. However, they say that there is some endometrial protection and no breast cancer risk. Low cost, if you think about, you're pretty much paying for the clinic visit and then the small cost of the medication. Some cons can be weight gain, extended time until fertility returns. It can be up to 18 months on average to conceive. So for people who might want to have a child or try to conceive a little bit sooner than that time frame, this might not be the right option for them. And then,
Sorry, and that's after you stop it.
yeah, so if you get your dose and then, it's like 3 months, on average it can take up to 18 months even after they've gotten it to conceive. But in general, it can still be like that after 14 weeks, they can ovulate and conceive, but it can be prolonged. So it's not as readily reversible as the oral contraceptives. Yes?
This is through a PCP.
Yeah, so they have to get it done at a provider's office. So yeah, they have to, that's another thing too. They have to go to the office and get it injected. All right, next is vaginal ring, a brand name that's common is NuvaRing. So this releases small daily doses of the active metabolite of desoestrol, and it also has estrogen in it, so it's like combined, but it's not an oral contraceptive. And then this happens over 21 days. And so they leave it inserted for 3 weeks and remove it for 1 week, and that's when they have their withdrawal bleeding. So it provides month-long contraception. So with this patient education in terms of starting, they would need to use 7 days of backup method if they were not previously on another hormonal contraceptive. If the ring comes out, rinse it with lukewarm water and reinsert. However, if it has been out for more than 3 hours, they'll need to use a backup method. So pros with this, it's also one of our more longer lasting ones, so less adherence issues in terms of having to remember to take a pill every day. There are fewer systemic hormonal side effects, and some cons might be local complaints, so like foreign body sensation, vaginitis are some of the more common ones. One that's similar to Vaginal System or Annovera is the common brand name. So it's fairly similar. It releases daily doses of the estrogen derivative and progestin derivative. This one, however, is made of silicone. So while it also provides month-long contraception, it can be used for up to 13 cycles. So they get this box and it's a year's prescription, basically. And I'll describe that here. So after 21 days, they remove it, they follow the instructions to clean it and store it, and then they reinsert that same ring after the 7 days of not having it in. Similar things in terms of if it's out for more than 3 hours, I recommend a backup method, and then if it comes out while they're still supposed to be on it, they can rinse and then reinsert. Again, with this one, pros, less adherence issues, and also they're having like one prescription, I guess, for the whole year, so they're not having to go to the pharmacy to pick it up every month. There are also fewer systemic hormonal side effects, and a prescriber is not needed for insertion as compared to like the Cobra IUD that we talked about previously, or the Depo-Provera injection where they need to go to the doctor's office. Some cons, this one has not been adequately studied in females with a BMI greater than 29, so just keeping that in mind. That doesn't mean that it's not effective, it just hasn't been studied, so we don't have the data. The transdermal patch, these are some of the more common ones. It's also a combined contraceptive, so it has the estrogen derivative and the progestin derivative. So this is applied on the arm, abdomen, or buttock, and not the breast. This is applied on the same day of each week for 3 weeks, and then the 4th week is patch-free. Bless you. And so this one, if they keep it on, if they forget to take it off and keep it on for longer than 9 days, they'll need to use a backup method. Pros of this one, it's weekly application, so not having to remember to take a pill every day. However, it can be confusing if you're having to remember to apply it once a week and then there's a week that you're not. Might throw off some people's schedule, but it can lead to increased adherence when compared to the pills. Cons, it is less effective in women that are greater than 90 kilograms, so it is not recommended for those patients. And it can cause skin irritation. Yes?
Does it matter which days they want? You know, since for every day of the week for 3 weeks, so does it matter which day of the cycle the woman starts using this?
So you can use like similar methods, so like doing it as soon as you get it. So those same initiation methods still apply. So they can start on the first day of their menses, or do the Sunday start method, or do the quick start method, and then just apply it on the same day of the week from there. All right, and next is the hormonal IUD. We talked about the copper one. So this is similar, but this one has hormones in it. So it has has progesterone, and so that, like we talked about, thickens the cervical mucus and prevents the sperm from entering, or the union of the sperm and the egg, and prevents implementation and growth. And so the efficacy is very high. It's similar to sterilization, and so like 99.95% efficacious in preventing pregnancy. And this one's also really good because it can be kept in for an extended period of time, the Mirena up to 8 years that it can be kept in. So really good if people have issues with adherence or don't want to take a pill every day or remember to go pick up their prescription every month. However, the cons, does have to be inserted in a provider's office. And then they also have to keep up with it and remember after 8 years whether they need to take it out. And for it to be removed, they also have to go back into the doctor's office as well. So it also has a quick return of fertility upon removal. Whenever we think of that compared to the Depo-Provera, which can extend people conceiving for up to 18 months, this one has a pretty quick return of fertility. However, the cons with the rest of the intrauterine devices, and those same contraindications apply in terms of the risk for upper genital tract infection. This has been associated with a decreased long-term fertility, and it requires medical intervention by the doctor or the provider, and people can experience heavier menstrual periods or irregular bleeding. All right, next we'll talk about the implant. General brand name is Nexplanon. So this is the active metabolite of desogestrel. So it gives decreasing amounts of hormone over 3 years. And so it prevents, suppresses ovulation. And so with this one, it goes in the arm. Usually you can see it if someone has it in, or they can feel it at least. But other than that, it's not terribly bothersome. The efficacy is similar to the perfect use of the combined oral contraceptive, so a little bit less than the IUDs. It is highly efficacious. It's more discreet, so less adherence issues, and there is no effect on bone mineral density or weight because it's a progesterone derivative. So cons can be regular bleeding, and then there is a procedure to insert and remove. I'll pause there for questions about any of those before we move on. All right. So talking about special populations to consider, this is just a brief overview. So women over 40 years, it's important to consider that 80% of women aged 40 to 43 can still get pregnant. This is actually the second greatest time for unintended pregnancy, second to teenage pregnancy. So most are perimenopausal, so they have decreased fertility, but not zero. And so there is limited safety data on the use of oral contraceptives in this population. However, the American College of the gynecology experts, they suggest that these can be used up to age 50 to 55 in healthy women. And then obesity, we talked briefly about the patch not being recommended in women with a weight greater than 90 kilograms. There is an association with increased BMI and contraceptive failure with the patch, so that's not something that we would recommend for those women. And it's also hypothesized that women with an increased body weight have increased basal metabolic rate and induction of hepatic enzymes, so they might metabolize the estrogen a bit faster, and that might lead to the decreased efficacy. That's the theory of the mechanism. All right, postpartum. So immediately postpartum, women are at increased risk of VTE. And so this is usually within the first 3 weeks after giving birth. And so with this, we think about our estrogen products, which also have an increased risk of VTEs. So we will not recommend those agents in mothers who have just given birth. And they can use progestin-only contraceptives in the interim if warranted. So they can start it after 3 to 4 weeks when the risk decreases. But in the interim, if they would like to start on an oral contraceptive or any contraceptive, we would not recommend the ones with estrogen in them. And then kind of goes hand in hand, but breastfeeding, estrogen can inhibit prolactin, which leads to less milk flow or can lead to less milk flow. And so with this, we also prefer progestin-only formulations in mothers who are breastfeeding. Progestin does not affect milk production, and there are no known effects on infant development. And so usually they recommend after about 6 weeks of lactation, when they have a stable milk production, then they can go back on the combined oral contraceptives if they so please. But in that interim or throughout the duration of their breastfeeding, progestin only is preferred. Any questions about those? All right, so now we'll talk briefly about emergency contraceptives. There are different ways and different methods. I will talk about first the one that's available over the counter. That's the levonorgestrel, or Plan B One Step is the common name for it. So this contains a progesterone derivative, and it's taken for the one step as a single dose within 72 hours of unprotected sex. Effectiveness is up to 89%. This is the most common one. However, it's important to note that it's less effective in women with a BMI over 25 and may not work in those with a BMI over 30. So in those patients, there is an agent, the brand name is Ella, and this has been studied in women with higher BMIs. However, it still might be less effective in those with a BMI over 35, but in that higher BMI range, we would want to recommend this agent. Only con with this one, it requires a prescription to be kept behind the counter, but this one can be taken up to 5 days or within 5 days of unprotected sex, compared to the Plan B One Step, which has to be taken within 72 hours. And then last one is the copper IUD, which we talked about. This one can be also used within 5 days of unprotected sex, and it's the most efficacious. Only cons with this one, it has to be inserted, so they have to find an appointment with the provider and go and do that, so it might inhibit accessibility. But outside of that, those are the 3 main ones, and there's no, in terms of weight, with the copper IUD, there's no data saying that it can't be used in women with higher BMIs. So that would also be an option for that population.
Excuse me.
Yes.
The IUD we see within 5 days, those are minors.
Say it again.
The IUD within 5 days,
Mhm.
plus and minus.
Well, no, this is for emergency contraception, so after. So plus,
Plus.
yes. They still can use copper IUDs as their primary contraception, but it's still, yeah. This is more emergency contraceptive. All right, general patient education. After taking an emergency contraceptive would be possible menstrual cycle abnormalities. So they might have either heavier or lighter menstrual bleeding after taking it. And then if they don't have menses within 3 weeks, they recommend taking a pregnancy test before starting any other contraception. And then if there is heavy spotting or severe abdominal cramping, it's recommended that they see a provider immediately because this might be a sign of ectopic pregnancy. And then obviously this does not prevent STIs. And then if they're already using a hormonal form on a regular basis, but they might have maybe missed some doses, it's instructed to begin or resume their regular contraception on the next day after they use the emergency contraception. And then after that, use a backup method for 7 days. Okay. If there are no other questions, we will go into the last section of the Kahoot. Oh no. All right. This is a recommendation for a product. All right, that's correct. So she would like to start contraception. However, she usually forgets to take her daily multivitamin and her migraine prophylaxis, so maybe not the best candidate for a medication that she would have to take every day or would have to remember to use. And so out of all these options, NuvaRing would be the best option for her. Okay, a breastfeeding mother that is looking to start contraception. What do you recommend? All right, yes, the copper IUD is the best option for her, just because with the estrogen, we talked about how estrogen can decrease prolactin and then reduce milk production, so we would recommend the red or the blue. Withdrawal method is not very efficacious. We didn't state how long after having the baby is she, so the copper IUD is is the best option out of the 4 because it has the best efficacy and it is safe for her since she's breastfeeding. Withdrawal method is never recommended. All right, last question. All right, yes, Ella or omeprazole acetate is the correct answer. The clues in this question is that she had unprotected sex 75 hours ago, so she is out of that window for the Plan B1 step. Then also her BMI is greater than 30, and as we saw, Plan B1 step can be less efficacious, and those with the BMI greater than 25 to 30. So in this case, we would recommend Ella. What questions do we have? All right, so let's see who won. Mike, congratulations. Yes. Congratulations. I don't have any prizes, but just take pride in the fact that you won.
Makes sense. That was you, right? Wait, you.
All right, so just to close out in general, just thinking about, I tried to introduce you to the concept, but thinking about your patient, if they present with certain symptoms and they're already on a contraceptive, what can we switch them to? That might be better or worse for that symptom. And then also if they have other like contraindications, choosing the best product for them. So possibly case-based questions and figuring things out from there. What questions do y'all have about any of the content that was presented? All right, sounds good. I'll stick around if anyone has any other questions.
Thank you.
Thanks.